Today, we're really pleased to have Dr. Guido Frank presenting on some of his current work. Dr. Frank is a professor in the Department of Psychiatry here at UC San Diego and board certified in adult, child, and adolescent psychiatry. His research focuses on developing translational models that bridge clinical presentation with neuroscience, advancing more effective treatments for eating disorders. He pioneered the application of computational model-based neuroimaging in the field of eating disorders and has used multimodal neuroimaging to develop models linking anxiety-related traits with eating disorder behaviors. More recently, his research is focused on investigating biologically based interventions to improve the treatment of eating disorders. So today, Guido will be talking about the results of his recent study examining the possible impact of cannabidiol or CBD in the treatment of anorexia nervosa. So, Guido, thank you again for doing this, and I turn it over to you.
Yeah, thank you so much, Tom. Thank you so much for having me. And let me share my slides. 1 second. So can you see that all right?
We can. That looks good.
Awesome. So we'll be talking about cannabidiol and regulating eating disorder symptoms in anorexia nervosa, and about this trial that we recently completed. And I thought I get a bit into the clinical presentation of anorexia nervosa first, so that we know what we're talking about and what problems we face in the treatment of anorexia nervosa. So anorexia nervosa is characterized by a restriction of energy intake relative to the body's requirements. So folks have a significantly low body weight in the context of age, sex, and development. So essentially, they starve themselves to emaciation and unfortunately often death. And despite being so thin, there's an intense fear of gaining weight or becoming fat. And while they're underweight, there's also this very peculiar body image distortion, it is called. So it's a disturbance how people feel themselves, how they sometimes even see themselves. So they experience themselves as fat while they are very, very thin. And shape and weight are typically the main driver of self-esteem. And very often there is very little understanding how serious and dangerous this condition can be. Aside from those core criteria, there are also important associated behaviors or traits. There's very high state and trait anxiety, high harm avoidance, high perfectionism, intolerance of uncertainty, and sensitivity to punishment. And these traits, they typically create a sense of ongoing pressure and stress because you always have to do more because it never feels enough. And then even after weight normalization, there's a high fear of eating. Weight concerns tend to be high, which is a problem to drive relapse once people have weight normalized. And the idea was then these fears go away, but they typically do not, just like that. And that is then similar to what's called atypical anorexia nervosa, kind of a milder form of anorexia nervosa, where people also have very high fear of gaining weight. They restrict their eating. They have lost at least 5% of their body weight, but have not reached underweight or not reached underweight yet. So it's like a milder form, if you wish, but they're also highly impacted and distressed. Eating disorders are severe psychiatric disorders with elevated standardized mortality rates, especially anorexia nervosa. You see on the left column about 5 times elevated standardized mortality rate. And this mortality, as research in different studies has shown, is very much driven by high suicide. People are in so much distress that they end their lives. So it's a highly dangerous condition, used to have the highest mortality among the psychiatric disorders and was just surpassed by opioid overdose in the recent years. So how can we conceptualize, think about development of anorexia nervosa or other eating disorders? such as bulimia nervosa or binge eating disorder. And the data and models that I show you, they're based on a relatively large number of studies that we have done over the years using different brain imaging methods and behavioral assessments to come up with an integrated model for how those disorders develop and why it is so difficult to overcome them. What has always struck me is how chronic eating disorders are. People go from food avoidance and emaciation to sometimes binge eating, purging, self-induced vomiting. They're preoccupied most of the day with shape and weight, typically excessively exercise. And despite the deleterious effects, such as significant medical adverse conditions, spending months and often years in treatment centers, there seems to be an intrinsic motivation that perpetuates those behaviors. And when I say intrinsic motivation, I'm not necessarily thinking about this wish to lose weight because of maybe the messages from the social media and whatnot, but biological mechanisms that really get in the way of recovery and getting out of this problem. And based on imaging and behavioral data, we have then created the following overarching hypothesis and model how those disorders develop and are maintained. So we have predisposing anxious perfectionistic traits that have been over and over found in research studies. People just don't feel good enough. It's never enough, and I always have to work harder. That's sort of the baseline condition. And then usually there is precipitating the onset of the eating disorder a specific motivation, such as I want to get better at sports. I exercise more over summer, and all of a sudden people have anorexia nervosa 3 months later. Others are maybe overweight, want to lose weight purposefully. Others had maybe a traumatic experience, do not want to feel their body, etc. So there's a wide range of possibilities that occur precipitating, but they all have in common is people have a motivation to change their eating. And what then happens is when they change their eating, that are a couple of important sequelae following. For one is there's a conscious learning and conditioning. Eating is bad, food is dangerous. So a negative conditioning to food and eating, which is processed in the prefrontal cortex and the amygdala. And that then triggers a circuitry from the frontal cortex to the ventral striatum, nucleus accumbens, and hypothalamus to activate the food control circuitry. And this circuitry was originally based for, if you wish, true danger. You are in front of a tiger at lunchtime, you're hungry, but you better run to not get eaten. So that's the circuitry to override your hunger in that moment to get to safety. And it gets hijacked by this conditioned fear of eating for other reasons. And that then is mediated through the dopamine D1 and D2 receptor, kind of a top-down control over appetitive drive. On the other hand, there are, I like to say, unconscious brain changes occurring, and they differ between the type of eating disorder, whether it's a low weight or more on the high weight eating disorder. In the low weight folks, such as anorexia nervosa, who have a maintained ability to restrict their eating, this low weight is associated with a sensitization of dopamine circuits. And paradoxically, because the food control circuitry also runs on dopamine, that sensitizes the food control circuitry and reinforces the ability to restrict. So a vicious cycle that is kicked off by the low weight and sensitizing of dopamine circuits. On the other hand, high weight eating disorders with binge eating, high food intake, such as bulimia nervosa or binge eating disorder, just like in an addiction model, those high food intakes, they desensitize the dopamine circuits, and by that, the food control circuitry, enabling intermittent binge eating. So the central role here has the ventral striatum, hypothalamus, that are driven by dopamine circuits. And all those eating disorders, they purposefully use top-down control to override appetitive drive, to control eating, but only the ones with low weight are able to maintain the low weight, and the other folks with higher weight, because of the change in the opposite direction of the dopamine circuits, they have then intermittent binge eating, and both have then this vicious cycle. Now, we treat those pathologies in different ways, and we have the conditioned fears of eating, weight gain, body image problems. So this food and eating that have become a threat, we treat that with psychotherapy. And on the other hand, we have the ventral striatum, the hypersensitized dopamine circuits in the case of anorexia nervosa, and the fear-driven food avoidance, which we, for over 10, 15 years now, we have been treating with a medication called aripiprazole, which is a dopamine D2 receptor modulator, partial agonist, which, based on animal models, supports cognitive flexibility and downregulates dopamine receptor hypersensitivity. I have to say there's limited evidence for that. At this point, it's not FDA approved. There's like more retrospective chart reviews that support that. It's very difficult to do randomized controlled studies in this population over a longer period of time. And we are currently looking at 800 patients retrospectively to further support that, but still work in progress. So psychotherapy is the main treatment modality. And as I already mentioned, during weight restoration, anxiety and distress over the weight gain and body dissatisfaction often rise, and increasing the risk of relapse. And no biological treatment has been approved for anorexia nervosa. This problem and lack of novel treatments has then also been emphasized in a recent meta-review of meta-analysis. So they looked at any study that was ever done and so forth, emphasizing the urgent need for novel treatments, especially in anorexia nervosa. It's a really good reason to look at novel treatments. And there are, as you I'm sure all know, there's a whole set of novel agents, or maybe repurposed older agents, that are in investigation, such as ketamine, psilocybin, hormones like metroleptin, brexanolone, and there's nutritional ketosis as a new intervention, and then, of course, cannabidiol, which is the main target for our talk today, although I will also get a little bit into nutritional ketosis. So cannabidiol is a cannabinoid. And what are cannabinoids? I'm sure you all know about that. I just briefly want to mention the different groups. So there are the plant-derived cannabinoids like tetrahydrocannabinol, THC cannabis, and then there's cannabidiol, CBD. There are synthetic cannabinoids, and then the endocannabinoids that the body produces itself, such as anandamide, and then they have vast effects across the body and brain. And of course, here we focus on cannabidiol CBD. Now, why would we consider CBD to treat in anorexia nervosa? So there are several mechanisms based from animal research largely that suggests that it could have a positive effect. So for one, CBD is a CB1 receptor antagonist, inhibiting the cellular uptake and enzymatic hydrolysis of endocannabinoids, so enhancing the endocannabinoids, an indirect action, but could help with changing mood and maybe anxiety via that route. CBD also binds to the serotonin 1A receptors, and past brain research has shown in several studies that the serotonin 1A receptor is altered, often elevated in anorexia nervosa. And this target might also explain its anxiolytic properties, considering that serotonin is highly associated with anxiety and depression effects of medication. And CBD also has a role in lipid metabolism and affects mitochondrial function, which has increasingly gotten attention in mental health recently. And there is some evidence that links cannabinoids to anorexia nervosa more directly. There is a rodent model for anorexia nervosa, the activity-based anorexia model that indicated elevated CB1 receptors, suggesting adaptive changes of this receptor. Some animal models showed CBD was associated with reduced fear expression, increased fear extinction, and disrupted fear memory reconsolidation. So having in mind that people conditioned with fear to food and eating, so that could have a really important role in treatment and alleviating these fears. Brain imaging in humans with anorexia nervosa showed increased CB1 receptor availability, just like the ABA model. Whether that has mechanistic effects is always hard to say, but one could think about maybe there's some reinforcing aspect to it. And then clinical studies in anorexia nervosa showed elevated anandamide levels and CB1 receptor mRNA. And a CB1 receptor agonist improved stress-induced reversal learning, suggesting that cannabinoids could enhance cognitive flexibility. What is extremely difficult in clinical work with folks with anorexia nervosa is helping them to go from one way of thinking to another, to let go of the food restriction and work on getting back to eating, which has been associated with cognitive rigidity. So the CBD, again, could have an important role here, and these were all motivators to conduct this study. And that brings us to the actual study that was recently published in the International Journal of Eating Disorders with Neha Sahota as first author. And again, I want to express my gratitude to the Center for Medicinal Cannabis Research for funding it. What we wanted to accomplish was, for one, is conduct a placebo-controlled, randomized, double-blind pilot study to establish safety and feasibility and tolerability of CBD in adults with anorexia nervosa or atypical anorexia nervosa. So the folks who are either underweight or have not quite reached underweight. And we expected that CBD would be well tolerated, not associated with any weight loss or other signs of relapse. We wanted to see whether pharmacokinetics would be as expected, meaning you change the dose and the blood levels would change accordingly, to rule out any specific metabolic abnormalities in that group. And third, of course, we wanted to test the clinical effects of CBD, and we hypothesized that the medication would, relative to placebo, decrease body and eating-related anxiety levels and be associated with increased weight gain. And weight gain is really the holy grail of eating disorders, anorexia nervosa treatment, together with reducing the fears around that. We recruited 32 cisgender females with a diagnosis of AN or atypical anorexia nervosa, and they had to have the condition for at least 6 months. And we were very careful with assessing, ensuring medical stability, using comprehensive medical evaluation, lab assessments, and EKG, and then excluded psychotic or other mental illness requiring inpatient hospitalization. We excluded drug or alcohol problems and so forth. Here is the flowchart for the study. We recruited study participants from the community as well as the UCSD Eating Disorder Center. They were all carefully screened and evaluated, and then had those 34 individuals who then were randomized to the experimental or the placebo group. As we already said, they had labs, behavior assessments on baseline, and then over 3 weeks, they received increasing dosages of CBD from 1.25 to 6.25 milligrams per kilogram twice a day. And then each week they came back to the ACTRI, had labs and in-person behavior assessments. And yeah, so that went on for 3 weeks, and we had one dropout in each group, and each one was for a rash. Data were normally distributed, which was very nice. So we could use parametric tests. We used chi-square tests for categorical variables. And then because we had a complete data set, we could use repeated measures, multivariate ANCOVA. And we did include comorbidity and medication as factors in the model to calculate changes over time in the CBD group compared to placebo. Here are the baseline demographic and some behavior results, and you see the CBD group and placebo group were very well matched for age, BMI, education years, drive for thinness, body dissatisfaction, also where they came from, like from partial hospital or intensive outpatient level of care or the community, what subtype they had in terms of anorexia nervosa, comorbidity, and race and ethnicity. So very, very well matched to study groups. And here are the pharmacokinetic results. You see how the CBD and metabolite levels nicely went up in the active group over time. And the anandamide levels, they were a little bit different between the two groups at time point 2, but it was not statistically significant. In the larger group, it probably would have. The meaning of that, I could not say at this point. But overall, the plasma levels of the medication and change over time was very reassuring and as expected. Regarding safety and tolerability, CBD was well tolerated, and there was really minimal side effects. One person reported abdominal symptoms that were very mild in nature. We had a comprehensive acceptability assessment using the treatment acceptability and adherence scale, and there were no differences between CBD and the placebo group. And the rashes that occurred in one participant in each group were non-specific. So when they came back, they said, yeah, I mean, it's much better again. And yeah, and then I saw a bit of a rash in each one of them. And we weren't quite sure whether it was truly from the CBD or placebo solution. And we decided to exclude them regardless, just out of safety concerns, of course, with a increasing dose the next week, and excluded them from the analysis. Now, here are the behavioral results, a little bit of a busy table, but I want to emphasize a couple things. One is BMI, body mass index change was small but significant in favor of CBD. So that was a true I have to admit, surprise, because I didn't necessarily expect it to be significant, and the effect size, despite the small overall value, was large. And then we had some other interesting changes, such as state anxiety, lack of control, overeating sense, and shape concern that were all improved in favor of CBD. Not significant for those values, but the effect size was again large in favor of CBD. And here I wanted to show you graphically the BMI change. Again, it's small, but significant, and significant for the group comparison, and the overall Wilks lambda for the change in the CBD group was significant and the one for placebo was not. So supporting that there is a difference in favor of CBD. Here are the behavior results. I think that looks really nice. In fact, you see the EDE global in the left upper hand corner, which is a composite score of restraint, indicating food restriction, eating concern, shape concern, weight concern. And they really start out at the same number. And there's this nice then separation over time in favor of CBD. You also see then the subscores where it separates for restraint, so food restriction, shape concern, as well as small, but still for weight concern. Eating concern, there was no separation visually, and the large effect size was seen in the shape concern comparison. So the 3 weeks of study duration was short, and other studies in being side literature, for instance, they favor study durations of 3 months or so, or maybe 6 months. And we would expect that a larger duration of the study might have then separated the groups further, but that's of course speculative. So in conclusion, CBD appears safe and well tolerated in women with anorexia nervosa and atypical anorexia nervosa, with the capacity to support weight recovery and some indication of improving eating disorder psychopathology. Study, we want to say, demonstrates the need for further research into CBD treatment effects and mechanisms. And we really would like to study CBD in anorexia nervosa in a larger sample over a longer period of time and test different dosages of CBD. Although finding funding has been not easy, I have to say, as a little caveat, despite the good results. Now, for me, it's always important to see whether we can integrate the study results of a new brain imaging or interventional studies. Can we integrate that with what we already know, with the idea of, is that something new maybe? On the other hand, if it ties into with other work we have done, I think it actually strengthens its likelihood of being a true finding. So we then looked into, can we integrate CBD actions into our current model? And just to recap, so the work that we have been done on anorexia nervosa neurobiology is largely kind of been around dopamine circuitry, like the ventral striatum, hypothalamus, dopamine receptors that kind of then are at the interface of conscious learning, behavior, and anxiety, in these brain changes that occur and then support the vicious cycle of the individual eating disorder pathology. What we have gone into more recently is metabolism and studying ketogenic diet in anorexia nervosa, with looking at mechanisms for glucose utilization and energy metabolism, GABA neurotransmission, and anxiety control. And this is something that might seem a bit counterintuitive to use in eating disorders, and I'm facing that almost daily, that it seems very counterintuitive and people wonder how that could be or make sense. But I will try to convince you in the next slides then why this would make sense and an important area to study. So, ketogenic diet in anorexia nervosa. What is a ketogenic diet? Well, it's a nutrition that's derived from 70% fat, 20% protein, and 10% carbohydrate. So essentially, you place sugar with fat as your primary energy source. Of course, weight maintaining. So we would want to make sure nobody loses weight. On the right side, you see this keto food pyramid with all the things in the bottom that you more or less cannot have, and then meats, nuts, seeds, vegetable oils, and then a bit of fruits and berries that are part of the diet. And what really you do in a ketogenic diet when you switch from using carbohydrates as a main energy donor to using fat. First of all, you use up most of your sugar that's in the bloodstream and deplete your glycogen stores in the liver. And then you use fat as your energy source. And fat is broken down into fatty acids and ketone bodies, and your brain switches from using glucose as the main energy source to using these ketone bodies. And this diet has been around for a long time for treating epilepsy, in the past treating diabetes and so forth. So it can be done safely. And now why could this have an effect in anorexia nervosa? And I put together in this slide, in brief, a model for metabolic vulnerability in eating disorders and making the case for ketogenic metabolic therapy. So for one, there's genetic evidence for metabolic factors in eating disorders. So there are genetic studies that link metabolic pathways in different directions with anorexia nervosa versus obesity, pathways that involve glucose metabolism, insulin signaling, and so forth, suggesting that altered metabolism, genetically altered metabolism, is a risk factor for developing anorexia nervosa. And then what I found is that brain glucose metabolism can be very much altered by stress and anxiety. Not in everyone, but there might be a subgroup of people who are really sensitive and vulnerable to that. And you remember, perfectionism, high anxiety is inherent to anorexia nervosa and also other eating disorders. And we hypothesized then that maybe this ongoing stress might interfere with glucose metabolism. And that is a real problem, right? If you're perfectionistic, you're working very hard, you want to accomplish things, and somehow you don't get the energy that you need. So that is a real, I feel like it feels suffocating to me, if you wish. So that could be then a metabolic vulnerability. On the other hand, starvation, what people with anorexia nervosa do, leads to ketosis and changes in this metabolism. As we said, ketosis provides this alternative fuel source that is potentially less impacted by stress and anxiety. Also, there's an increase in GABA production in the ketosis state. So enhanced GABA could help with lowering the fear and anxiety that people typically experience. It also reduces inflammation. And we all know that inflammatory markers are typically elevated in psychiatric disorders in general, including anorexia nervosa. So then we came up and published a model that starvation reinforces restriction anorexia nervosa, right? Because you get into starvation mode, you have the ketosis, and people often tell you this has some sort of an addictive quality to it. And these ketone bodies that provide you a more efficient energy source could be then your solution, right? It feels good and feels better. And unfortunately, at the cost of depletion of your body and death. On the other hand, a weight-maintaining ketogenic nutrition that mimics the starvation state, but provides you enough calories that you do not lose weight, then could solve the problem because you have this alternative energy source that supports your brain function. You have an enhancement of GABA and a reduction in anxiety, and you overall feel more stable with your energy level and feeling more capable. So that was the background information and model that we have been working with. And we then received funding to conduct a study using ketogenic therapy in adults with anorexia nervosa. That was just published recently in Communications Medicine. I'm also happy it got featured in Scientific American and other outlets. So the important message from this study was that while the ketogenic therapy was well tolerated, there were no significant concerns, and weight stayed stable and all. There were significant decreases in eating disorder symptom scores as well as depression scores. So very impactful in improving the psychopathology and indicating that ketogenic dietary therapy could be a potential intervention in this population. And in the next slide, I just want to show you real quick some symptom score changes on the left, the EDEQ global, again, this composite of restrained eating, shape, weight concerns. And you see from pre and post intervention, dramatic decreases of symptom scores. 72% of the study completers were within normal at study end. And after the study on the naturalistic follow-up, 3 months, many of them went back up with their symptoms. The ones in blue did not maintain keto. The ones in black did maintain keto nutrition. On the right side, change in BDI depression scores. Again, you see people from 40, 50 score down to below 10. So dramatic decreases that people experienced. And then for especially the ones who did not continue the diet, there was like back an increase after the follow-up period. So indicating for a large number of people a dramatic improvement in symptoms. Now, going back to our overall neurobiology model and question, can we integrate CBD somehow between the dopamine and the metabolism aspects of anorexia nervosa neurobiology? So I then started searching, and I was surprised, pleasantly surprised, because it kind of seems to fit in many ways. So CBD affects reward and learning circuits via the dopamine D1, D2 receptor. It facilitates extinction and reinstatement. So raising the hypothesis, well, modulation of dopaminergic circuits via CBD could support adaptive learning in psychotherapy, and then, of course, reduce relapse risk and support recovery. And then there's also metabolic effects such as cannabidiol improved glucose utilization. In 2 small studies, I thought that was very exciting and very much along our metabolism model that we have been most recently looking at. And it also reduces neuroinflammation. So coming up with then hypothesis 2 that improved metabolism and reduced inflammation biologically could support brain health and treatment response. So I thought that was, to me, super exciting. And then lastly, I'd like to show you then our expanded model for anorexia nervosa pathophysiology and how we think it might develop and be maintained. So person at risk for anorexia nervosa has these predisposing traits for anxiety and perfectionism. These folks are typically highly motivated achievers, but they often worry. And all that creates a lot of stress. Eating disorders, anorexia nervosa, as other psychiatric illnesses, often emerge during puberty. Puberty is a time of change and instability. There's increased brain energy demands, and you need a well-functioning glucose metabolism. There's psychological instability, lots of peer media influences, ideal of thinness that drive your conscious behavior. And then there's, of course, instability of sex hormones and neurotransmitters. And we have largely focused on the dopamine receptors that are part of development. And so we postulate that this high stress in folks with anorexia nervosa interferes with these brain energy demands and glucose metabolism. On the other hand, these psychological factors, they trigger negative conditioning to eating, food, shape, and weight. And then it comes to change of eating, food restriction, and weight loss, in particular in anorexia nervosa. Now, this change in eating changes your metabolism, and you enter a state of starvation and ketone production. And the ketone production then fulfills the unmet energy need. So finally, I have energy I can use, right? Feels good. And that would then reinforce further starvation. We have one vicious cycle to reinforce starvation, because it is wild, right? How anorexia nervosa makes you do exactly the opposite what nature tells you, right? You starve yourself to death. So one reinforcing cycle could be that, but then there's probably other reinforcers, such as you have this increase of transformation from glutamate to GABA, which then decreases anxiety, and then we have a second reinforcing mechanism. And lastly, the psychological parts, negative conditioning, activates this food control circuitry, mind over matter, controlling appetitive drive, and that further facilitates food restriction and negative conditioning, right? I don't want to do that. I'm afraid of gaining weight, which then sensitizes the dopamine receptors, the underweight, and then paradoxically strengthens the food control circuitry because it runs on dopamine, which then further facilitates change of eating and food restriction. And then we have unfortunately, a third mechanism that supports that reinforce anorexia nervosa behavior. And then treatment-wise, we could think about the dopamine D2 receptor modulators to interfere with that mechanism. Then we have the therapeutic ketogenic diet that provides a different energy source to help with the unmet energy needs, but also enhances GABA. And then lastly, factoring in CBD, I want to pose a hypothesis that the metabolic effects that affect glucose utilization, and then the reward learning and fear extinction effects then could have a beneficial effect in both directions. So both on the metabolic side as well as on the fear conditioning and dopamine mediated side. So that's our newest and latest model. And with that, I would like to thank all the collaborators and people who helped with this study. And thank you so much for your attention, and